Hello, my name is Dr. Roger Blumenthal, and I'm editor-in-chief of the new dyslipidemia clinical community, which is now available on CardioSource. Today, it gives me great pleasure to talk with my longtime friend and colleague, Dr. Sanjay Kaul, who's professor of medicine at the UCLA David Geffen School of Medicine. Today, we're going to discuss adherence to randomized controlled trials to develop guidelines and compare and contrast if that might work for other things such as high blood pressure. Sanjay is clearly one of the leading authorities in the world of cardiology. And Sanjay, I wanted to get your opinion first about these guidelines say they're strictly based on randomized controlled trials, and they really didn't take into account observational data. And maybe you might comment on your thoughts about the fact that we don't have now lipid targets, yet we do have some observational data that lower numbers are better. So what is your thought about this area, Sanjay?
Well, first of all, good morning, Roger. I'm delighted to be invited for this discussion. Basing guideline recommendations entirely on randomized clinical trial data is a laudable goal, but the reality is it's not practical, it's not feasible. And in a 2009 JAMA report on the strength of evidence informing a guideline recommendations, they found that about half of the guideline recommendations were based on lower level of evidence, meaning they were derived from either case reports or expert opinions or observational data. And there are other reports based on other professional society guidelines that only a handful, about a third to one half of these guideline recommendations are based on high quality evidence, based on well-designed, well-conducted randomized clinical trial data that yield consistent treatment effects. So it's very interesting to see that the claim is that all the lipid guidelines are going to be based on high-quality randomized clinical trial data. I'd like to see that.
Well, Sanjay, one of the surprises, I think, for a lot of clinicians is the idea that if you're above this 7.5% threshold for heart attack and stroke over the next 10 years, that even if your LDL is in that 70 to 100 range, you should be treated with moderate to high-dose statin therapy. And as you know, I think it was really just Jupiter that had a relatively low LDL, which was a median in the range of about 110. So I was curious what your thoughts would be about individuals who may have a high risk score because of the date of their birth certificate, and maybe they had smoked, and maybe their blood pressure is high, but yet their lipid values would be in the optimal range, at least based on what we had thought of before November.
Yeah, this is a very interesting, rather controversial issue amongst the lipidologists. Should we treat based on the baseline LDL cholesterol levels, or should we treat based on the underlying baseline risk? And the supporters of the latter base their arguments that the beneficial effects of statins may not only accrue from the LDL lowering properties, but perhaps they have these so-called pleiotropic effects. Some of them may be mediated through the anti-inflammatory effects. That's what's driving that argument. But if you look at the totality of evidence, there is reasonable argument to support the contention that the benefits of lipid lowering are related not only to the baseline LDL levels, but also to the proportional reduction in LDL levels from statin therapy. There was a thought experiment, or rather a simulation experiment done by Hayward and Holland Krumholtz. And they observed that a tailored therapy where you put patients, regardless of what their LDL levels are, and you treat them with high-dose statins, they yield greater benefits in terms of number of events provided and in terms of being more cost-effective than a treat-to-target strategy. But truth be told, none of the randomized clinical trials have evaluated what the ideal treatment target should be, because the patients were not randomized to a target LDL level. They were just started on a fixed dose statin, and what we observed at the end of the trial, what the median LDL levels were achieved with the low dose versus a high dose of the statin, and that's what the recommendations are based on. So I would personally support treating patients based on the underlying risk. And it's interesting to note that they use a threshold of 7.5% 10-year risk of CHD and MI. The European guidelines, particularly the NICE guidelines in UK, basically endorse only a 20% threshold for initiating lipid lowering, and that may be related to some non-scientific reasons in terms of there's certainly financial pharmacoeconomic reasons involved there.
That's a very good point, Sanjay. I guess another surprise is that the focus of when you add heart attack and stroke, lower that threshold from what used to be a 10% risk of a heart attack. Now we have a 7.5% risk of a heart attack and stroke. They justify this partly by saying that in low-risk people, we see a greater relative risk reduction in trials. However, the absolute benefit in these low-risk people is very small. So you bring up a very good point, and how will clinicians around the world try to incorporate the Canadian guidelines with European guidelines and guidelines here in the States? What is your recommendation to clinicians who may be outside the United States, and how should they interpret these new guidelines?
Well, I mean, the fact that there is variability in guideline recommendations across geographic boundaries doesn't surprise me, because ultimately, evidence-based medicine works best when it informs our judgment, not replaces it, and when it respects the preferences and the value judgments of the patients, and they are bound to vary across different geographic boundaries. The reason why the European guidelines are more strict is perhaps more to do with cultural and societal norms, as well as the financial budgets that are being allocated to their healthcare programs. So I'm not surprised at all with these variations. I think the Canadian guidelines are very reasonable. I've seen those guidelines. They've been in the public domain for the past 3 years. I've not seen the latest iteration of the ATP4 guidelines, and I reserve my judgment until I see them.
So Sanjay, getting back to randomized clinical trials, we talked about that these are statin-centric guidelines, and they say that there really just isn't enough data about adding on a second agent. You've written about the ACCORD study, and where half of the people had statin alone and half of the people had statin plus fenofibrate. And if you do that subgroup analysis of those individuals whose triglycerides at baseline was greater than 200, I think the p-value came very close to the usual bar of statistical significance of p equals 0.06. Yet this was a study that had maybe a median triglyceride level of around 160 or 165. So these guidelines did not endorse giving fibrate therapy to individuals with diabetes whose triglycerides are above 200, but a lot of people would say there was at least a strong trend, and that's why we probably should pay attention to non-HDL. I'd be curious about your thoughts, since this was an RCT-driven document.
Yeah, it's a very interesting question. I mean, even though the dyslipidemic subgroup was pre-specified in the ACCORD study, it becomes difficult to interpret a positive subgroup when the overall study failed to meet its primary endpoint, and it becomes an issue of whether this is a false positive finding or not. And so, subgroup analyses are always tempting, but as you know, they can be treacherous. We've been fooled many times by subgroup analysis results, favorable subgroup analysis that failed to be confirmed or validated in prospective randomized trials. So the way I look at these data are that these are hypothesis generating data, and we should be very careful in not basing our guideline recommendations called from a subgroup of a failed randomized clinical trial. And the same would apply to niacin. So I can see the dilemma that the guideline developers are in, that if you have patients on the background of statin therapy, if you add fibrates or if you add niacin, that there's no incremental benefit derived from the combination therapy.
Well, Sanjay, as always, you gave very insightful comments. We want to thank you very much, and we want to thank all our viewers here in CardioSource. Please join us and stay with us as we try to expand the dyslipidemia clinical community. And Sanjay, we'll be calling you in the future to give your insights many times in the coming years. So thanks again.
Well, thank you, Roger. I'm delighted to be able to do this with you.